everybody. I'm Lee Bakir, President Polio Network. Happy about the big turnout. I see we also had to add some tables, which is great. Just a reminder, turn off your cell phones, everyone, or put them on mute at least. There's a great program planned by Post-polio, longtime friend Dr. Hirsch here. And also, what? Is your mic on? Yeah, is it on? Hello? Okay, and also to share stories about family life with polio parents. Want to give thanks to Murray. Where's Murray? Murray? Just raise your hand. Murray over there. It was actually Murray's idea to, he's a longtime board member, for suggesting that we do invite family members to a conference and give their perspective on a relative who had polio. Okay, cameras are here. Everyone noticed them, I'm sure. This is being cast over the internet, and people will have the opportunity to chat with each other. Other people are also viewing this. It's being broadcast right now live. And they will also be able to submit questions to Dr. Hirsch. We have some other welcome guests here. I'll mention them later on when we have more time. Sorry about the delay in getting everything ready. Things happen. And want to thank Ray over here who handled the registrations and everything. Great job, Ray. Except for the tardiness, but that's okay. We'll forgive it. And as many of you may know, Arthur Siegfried, who was our past president and a good friend of mine, passed away last month. And I just want to give a moment of silence for him, if everyone doesn't mind. Thank you. Thank you. Okay, moving right along. Here's Dr. Hirsch. He's not only honored, but we're very pleased to have you here today. And he's also featured in our newsletters, which you might find outside. And okay, you can start. Thank you so much, Dr.
Thank you, Lee. I am multiply mic'd here, so I hope everybody can hear me from anywhere. And I want you to know I really trusted when Lee came straight at me. I didn't budge 1 inch. Lee is a friend, and there are many friends in this area, in this room, and it's kind of a special terminology. Late effects polio and post-polio syndrome and polio is something that is a long-term, lifelong process. And so physicians who are dealing with patients with this really get to know them well, and that's a special privilege. I did know Arthur, and maybe as part of this process, I have asked to consider this the Leonard Blumberg Memorial Lecture. It could have been the same for Arthur and for many others, and it was just the timing of this when I accepted this. Leonard met his demise. For those who knew Leonard, he was friendly and warm and generous and smart and giving, community-minded, and a pleasure to deal with in every stage of his life. He was dedicated to all of the communities that he was part of, and I looked forward to the times that I spent with him and looked forward to be able to give this lecture in his honor and memory. The first slide up here is the Hillsborough Playground Project, and you must think that I've got the wrong slides on or be at the wrong place or be the wrong speaker. But I wanted you to know that I'm grateful to this organization for donating to one of my pet projects. This past year, we built a handicap-accessible playground in Hillsborough. This came about through all privately raised funds, and this is meant for children with disabilities to be able to play alongside their brothers and sisters who don't have disabilities. This was the 13th of these playgrounds that I've been involved in, and it was a project that I started as a member of the board of the American Academy of Orthopaedic Surgeons when I made a recommendation that we build a playground, something that I had heard about, that was accessible as a metaphor for what we would like to do in orthopedics. Reduce the barriers to function, recognize the importance of play, and contribute to the safety of play areas. and we helped set the standards for playground safety. We've built them at each time, and actually I'll give you my board did, it's probably what your board does. They said, go ahead, but we don't have any money for you. And boards are very good at doing that. And it was surprising that it was not a hard sell. We went around to those people who we dealt with, and I will say, since they're a neighbor here, Sanofi Aventis was a new company at that time in the United States. They were primarily a European firm, and at that time Sanofi gave us a donation of $100,000, a major step towards that. And they've done the same thing every single year. And we're grateful to them for that bonding that we've had in this project. And we've built handicap accessible playgrounds in San Francisco, San Diego, Dallas, Chicago, Orlando, and cities across the country, and donated them. New Orleans, we built 2, one before Katrina, one after Katrina, and our playground withstood Katrina. Wasn't in the right area, so wasn't in the wrong area, I guess. So after building them around the country, I really wanted one in my community. And this was something that was very important to me, and once again, I thank you for your contribution. This was a community effort. The Hillsborough Township was wonderful. They donated their services, their land, and we had a wonderful group. At our academy meetings, we usually have orthopedic surgeons and industry get in there. And it's a fun day. We start with a piece of level dirt in the morning, and at the end of the day, the children are playing on it. So we do this all in one day with some consultants. This was the first that children were involved in the building. We've usually excluded them, and I assume for legal reasons, but the community in Hillsborough involved the children, and I think it was a good lesson and something I was very happy for. This is what it looks like in the background, and I'll now get on to why you really came here. The Polio Network of New Jersey has had a presentation, annual meeting every year. This is my 3rd event, and it's something that's close to my heart. This is an image of the polio virus. This is a model of it. It's a tiny little thing. It's about the size of DNA. None of us could see any of this. And the havoc over the centuries that this has produced is amazing. Because it's so small, it is easy for it to be something that's missed. And we had a lot of confusion about it. And even probably until the middle of the 1900s, there was a lot of debate as to what caused it, how it traveled, why we got it, why some people got it, why some people didn't in the same household. And those are things that we now have answers to. But it wasn't that long ago that we were confused about this. It was called for many years infantile paralysis, and our literature goes back a couple of hundred years, naming that there are 3 types of viruses, simply named 1, 2, 3. And a number of years ago, and this number hasn't changed, I don't believe it's still an accurate number, but we estimated that there were probably about 250,000 US post-polio survivors. Probably the number, depending on how you estimate it, is higher or lower. Number one, when this was done maybe 10 or 15 years ago, some of those polio survivors are no longer with us. But there were many people who had polio and didn't know it. In the medical community, if somebody had a mild case of polio, the physician was not anxious to make that diagnosis. It usually meant taking that child away from his home, away from his family, away from his parents, away from his loved ones, and putting him into a hospital. And that was a tough situation for everyone. As you might think, taking your young child and putting him with strangers, giving him to strangers, and subjecting him to that isolation, some of you were in that situation, is really a tough thing. And so I will occasionally see patients in my office who have all the stigmata of having had mild polio, and they don't know it. I'll see them with a shortened leg, some muscle atrophy, some weakness, symptoms of post-polio, and yet they'd have no memory, and when they go back to their family, no memory. So I think at times it was either subclinical, or at times they or their family were not aware, or their doctor and family were aware but didn't make a big deal out of that. It primarily affects the anterior motor horn cells. The virus is very specific, and that's pretty true about viruses. They go after one kind of tissue. The polio virus won't affect your heart. It won't involve any tissue. It's anterior motor horn neurons. It's only motor neurons, and that's why it's one of the neurologic disorders that involves motor function, but not sensory function. So if I have a patient who has absent sensation, I have to look for another cause in what's going on. Polio, we've learned, is traveled through the mouth. We inhale it by water, dirty hands, dirty food, contaminated food, not washing our hands, and probably still for many diseases, the best prevention is clean water and washing your hands and soap. And they have estimated at how many millions of people could be saved from many diseases, not just polio, by a little soap and water, sometimes the simple things. It goes and it gets into our system via the GI tract, the walls of your intestine, and even in those patients who don't have a severe form, they may shed that virus. And so that's why we saw strange demographics before we fully understood that. The majority, and whether it's 95, 99, or as it says on this slide, 99.5% of people, really don't have any major problem with it. They get over it. They may have a little fever, a flu, achiness, and get over it, just like with any other mild illness. In a small percentage, depending on, and we don't really know that number, but a small percentage of patients, it attacks the central nervous system. Many of those patients get over it with minimal problems, but a significant number do not, and those are the number of you in this room. It's highly infectious. Even those people who did not have clinical polio, other members of their family most likely were involved. And when we are able in other countries now with our viral typing to test families of those patients who have clinical polio, we find that the antibodies are often high in other members of their family. About 1 in 200 get paralysis, and about 1 in 1,000, historically, not currently, have a respiratory death. And that's primarily where it is bulbar. 80% is spinal, not bulbar. Bulbar involves the lower part of our brain that controls our breathing. And that's where the iron lung came in at that time. And about 20% of people had some elements of both. Those people who may have primarily had spinal, but who are at this time experiencing respiratory difficulty, difficulty swallowing, difficulty speaking, probably had some degree of bulbar involvement. The involvement was usually asymmetric. It's not perfectly symmetric. And once again, that's a difference when compared to many other muscular disorders or muscular dystrophies, which are typically symmetric. Right, left are equal. Polio was rarely symmetric. Our historical records in writing, and we don't have a lot of those, go back to medical meetings that occurred. And it's kind of interesting. Our various major cities in Italy and France and Britain and Germany all had small medical communities. And these medical communities would have discussions very much like this, probably not double mic'd and being video recorded, but otherwise being recorded. And Michael Underwood described what we can point to as polio in the late 1700s. There were outbreaks of what we can identify as polio in the 1800s and shortly after that in the United States. The epidemics were primarily summer, fall. They were not in the winter. And you might expect that between children being outside, children playing in water, and it would be easier for them to get for epidemics to spread the disease. The 1952 was our last epidemic, and in the 50s, I don't know if that 21,000 number is accurate because I've seen a number of different numbers. It was probably a little bit higher than that, and 1979 was our last case of what we call wild polio. We've had vaccine associated paralytic polio since that time, and that's with the Sabin vaccine. The image you're seeing in front of you is one that you may have seen before. This is from Egyptian tombs, and it is an image that's about 1800 BC showing what looks like polio atrophy in the leg. There are other disorders that could look like this: birth defects, birth injuries, other neuro injuries. What happens to the muscle, and what you're seeing on our left, I guess yours as well, on the left is a normal muscle, and what you're seeing is atrophy of the muscle. The muscle atrophies, it fibroses, it's smaller in volume, it doesn't have the strength, it doesn't have the endurance, and sometimes it doesn't have any function. As it fibroses, the joints are less well protected. The muscles serve as shock absorbers to the joints, and without that firm muscle to help it, we lose function. 1916, there was a large outbreak of polio in the United States, and bringing us into modern times, a very important process was in 1921. This affected Roosevelt. He was not president at that time, and he was left with severe paralysis. You can see over here Roosevelt after it. It may show a little bit that his right leg shows the atrophy. His shoulders are powerful. His look is strong. And you can see that this was somebody who is a strong, healthy individual until you look down to his legs. Once again, many of the pictures, and we've discussed this a little bit before, many of these were pictures that were at least semi-staged, and I'm not offended by that, to be honest. I think most pictures that we take are staged, and this was part of the person that he was.
In 1921, the disease struck an especially prominent citizen, just as his political star was on the rise. Polio usually targeted children, but Franklin Delano Roosevelt was 39. After contracting a sudden fever and chills, he lost the use of both his legs.
This was a major process to Roosevelt and his family. His mother was the dominant force in their lives, maybe in other lives as well, more so than his wife, Eleanor. What she really wanted him to do was to come to Hyde Park for her to take care of him. That was not the route that he chose. And he heard about Warm Springs and at that time traveled down there because he had heard that this was something that would have a positive effect. After going there, this was something that did have a positive effect on him. It didn't cure his paralysis, but it was a place where he functioned very well. And in the warm water, he, as many of you have found, the buoyancy relieves many of the much of the muscle weakness and the loss of strength and the loss of endurance. And this was important enough to him that he purchased the Meriwether Inn, and that became
The fact that he came down with polio changed the course of the disease in this country.
Roosevelt worked to restore both his body and his career. He bought a remote Georgia resort whose spring-fed baths were reputed to have healing powers, and turned it into the Georgia Warm Springs Foundation, committed to rehabilitating polio patients from around the country. In 1928, a still paralyzed but vital FDR fought his way back onto the national political stage.
We'll bear with the audio, and I must say, I've tried to make this to include these videos because I think they really give us a nice picture and a history of this, but I knew that this was not going to be necessarily easy. You can see the difference with, and you'll see some pictures later on. In the water, Roosevelt was a different person, and it's why he spent so much of his time down at Warm Springs. He was able to function differently. He had a different level of activity. He was able to be with other people and act really in a normal way. It's hard to imagine any of our current presidents being in a pool. Am I on now? Okay. I've always felt I could talk loud enough for any room, but I guess it's better if I have this. The publicity that surrounded FDR's desire to be in the Warm Springs was something that not everybody had access to, a warm water, spring-fed pool, and various rehab facilities became pool-based. And these were something that, particularly with children, were very effective in maintaining motion, strength, and endurance. I don't think this patient probably went back in a pool a second time. I took this picture. There was not really great equipment available. Some of you have pools. There have been lifts devised since that time. But I'm not sure what happened after this, whether all three of them got wet. But it certainly looks like that. But this was before video, so that's the only picture that we had. Moving along, in 1928, a very important event, the iron lung was developed. And this allowed for patients who had bulbar polio to be sustained during the course of their treatment. And at times, in some of our larger institutions, this is what a polio ward looked like. Scary. Hardly any of us have had a time when there's not a little bit of a brownout in electricity, or when a thunderstorm or the like of that come by, and they had this, where there would be electrical failures, and they ran around doing these things by hand with every single staff that they could mobilize, and my guess is at times that wasn't enough. But this is an actual picture. The look on this child's face is easy for you to see. He's not happy, and you wouldn't be either. It's scary, it's uncomfortable, and he's not with the people that he loves. This was a wonderful advance, but certainly not everything. There were birthday parties, and they called them iron lung parties. I'm not sure if the patient is quite as happy as everybody else looks, but it was a common finding. It was part of life, and it was part of treatment, and in ways made it normal or more normal by having visitors. The Queen would visit the children, celebrities would visit. This is pretty much what it looked like, and that iron lung I'll show you a picture of. This actual one was at one of our exhibits recently. This, I don't know if it shows as well, is the nurse is holding a baby, her baby. Polio affected people at various times of their lives, including while they were pregnant. And this was a baby born to somebody who was in an iron lung. So it was an extraordinary process, and most of the patients who were sustained during this time were able to advance to the next stage. This is that iron lung that we saw a couple of pictures back, and it's what it looks like at one of our recent exhibits, and probably, certainly most physicians practicing today, with rare exception, have never really been where they see a patient who has been involved in this. I gave a talk on late effects polio to a group, and there were several older physicians. They were extremely animated. They had all dealt with polio. Polio was an important part of orthopedics prior to the vaccines being developed.
To keep the fight against polio alive, Roosevelt turned to his law partner, Basil O'Connor, a man who knew little about polio, but a great deal about power and persuasion. "I was never a public do-gooder," O'Connor declared, and had no aspirations of that kind. Short-tempered and relentless, he was a working-class Irishman who had to dig and fight for everything he had achieved.
Basil O'Connor has no interest in being the head of the Warm Springs Foundation, but he is so loyal to Franklin Roosevelt.
These pictures are of Basil O'Connor, FDR's law partner. And Basil O'Connor was someone who was dedicated to Roosevelt, and we'll go through that, and was instrumental. It wasn't his real focus. His real primary dedication was to FDR, but his dedication subsequently came to the fight against infantile paralysis, which it started, and subsequently to raising the funds that eventually funded the development of vaccines and cure for polio. And it went on long after Roosevelt was president. Going back to our date lines, in 1932, FDR was elected president, and 2 years later, polio was an important, fighting polio was an important part of his ethic, and he had the first 2 years later birthday ball, in which money was raised to fight, to support the Warm Springs Foundation, which he had bought, but also to fight polio. In 1935 was the first of the vaccines that became popular, and there was a great deal of effort to be the first to develop the vaccine. Fame and fortune followed that person, and it was something that physicians worked very hard at. The field trials failed on this, and that understates it. Children died, and that's what happened with part of this. In a lot of our early efforts, this was not fooling with something that was simple. There were dangers to the development of this. The National Foundation for Infantile Paralysis was sort of started in 1937, and again, the terminology fighting infantile paralysis was the term that was being utilized. And Basil O'Connor built this very successfully. should be some other sound, so I'm going to provide the other sound. The need for raising funds during the Depression could not have come at a tougher time. Raising money during the Depression cannot have been easy. In addition, this was a time when polio was on the rise. We had more children involved, we had less in the way of funding, and getting money from the rich, which is what most charities were at that time, was almost unheard of during the Depression. You have to remember also that hospitals at that time were either charity or private hospitals, and that really meant that you either didn't have money to pay for it and you went to a charity hospital, or you paid privately. There really were not the insurance plans and maybe the British term schemes that are currently available. And so you either went to a charity hospital, and they were named charity hospital, New Orleans Charity, Atlanta Charity, or county or city hospitals. The county and city and charity hospitals had no business department, no billing department. You didn't get a bill in doing it. So it was challenging for many people before to get the care, and it was the March of Dimes that promised them that. This is an article from 1934 in Time magazine. And I have it up here because there's such a change in our language and what's politically correct. This says, as the foremost cripple in the world, this was in Time magazine, the American Academy of Orthopedic Surgeons wanted President Roosevelt to attend their banquet in Manhattan. I have it a little larger. They asked one of their colleagues, an orthopedic surgeon, Michael Hoke, to invite the president. Roosevelt stated that he regretted that he couldn't leave Washington, but I want to tell you that your aim happens to be one that is closest to my heart. It's largely through your work that the world has progressed so far in prevention of deformity and bringing up straight children. Orthopedics really means to straighten the child. Ortho is to straighten, and pedics is children, so that's part of it. The March of Dimes terminology was not from Roosevelt and not from Basil O'Connor, but really was from Eddie Cantor. And just as today, with Haiti and Japan and Somalia and other places, we have many of our Hollywood celebrities involved. Eddie Cantor was probably as prominent a celebrity as existed in those days. And when someone on radio said, I want you to send your dimes to the White House, this was a powerful statement. And in fact, the dimes came in. Again, I'll see whether this comes through properly. Basil O'Connor was really in charge of the March of Dimes and the fight against infantile paralysis. And although I guess, at least initially, he was not somebody who was a deeply sympathetic individual, he was an extraordinary organizer and helped develop the March of Dimes, and they came flooding in. The March of Dimes received in its first effort following Basil O'Connor's outreach and the Hollywood outreach, a little over $1 million. And in Depression dollars, that was probably about $20 million in today's terminology, and enough to pay for hospitals and care. Almost everywhere you went, there was a iron lung with a little hole on top to put your dimes in. If you went to a food store and any other place, these were part of it. And in all of our magazines at those days, Saturday Evening Post, Look, Life, and so on, these advertisements were present on a regular basis. And so what we had was a full-scale push. People wore the little buttons and badges that identified them, and there developed over a time thousands of chapters of March of Dimes efforts to raise money around the country. They were effective, they were successful, and they brought in the dimes, the nickels, the dollars that built hospitals, provided care. Roosevelt continued to popularize this. He met with children, and this was the photo opportunities with visiting these children were always promoted. They may have served his political career a little bit, but they served the treatment of polio a great deal. We're not getting sound on this, and I'm okay on that. I can provide all the sound. This is really just showing that enlisting the communities, the actors and the actresses in almost every single way in every community was a very powerful force in raising funds. Almost every community had its March of Dimes. It was part of your daily life. People went from door to door. Organizations looked to raise the funds, and it was again under the direction of Basil O'Connor that these funds were raised on a consistent basis throughout the country. It was kind of interesting that at this time, this disease, polio, at that time for the children, was very interesting. It probably was not the most deadly disease in the country. Probably more children were killed in road accidents or by other diseases at the time, but it was certainly a disease that touched everyone's heart. Every parent, and I certainly remember my parents, was concerned. Tricky acoustics, and that's fine. Every parent was concerned every summer, and certainly everything you could do if you heard there was a case of polio, your child was almost limited to a small environment. And I remember that and a few other things that I'll go through with you. But parents were frightened, parents were appropriately scared. It was a scary process, probably as you might expect. It is sometimes likened to the AIDS of the day, and I'm not sure that I can do it because it was little children, your child, and your heart goes out to your child different than it does to almost any other loved one. Sister Kenny was a very important factor in the treatment of polio. It's very interesting because most of Sister Kenny's popularity was in Minnesota. And I have the feeling they're tougher in Minnesota than we are here in the East. Sister Kenny's treatments were tough. She would take the children, and the treatment involved putting hot packs on. Well, many of you in physical therapy have had hot packs, and they feel pretty good. The hot packs she had were the hottest they could make it, and they burned. I mean, these kids were not happy with this hot pack. They were in pain. And then she would move every part of their body. Those techniques probably were not that validated in subsequent years, but what they really did was create a one-on-one between the treating nurse and the patient. And I think that was vital to the success. These children were not in bed for more than a short period of time without someone treating them. They were not allowed to think that they were not going to get better. It was, you will get better, and almost as an order, not a question. And I think that was a very powerful process and has made those people who have survived polio into a unique group. They are almost, to an individual, successful, have overcome their condition, an important part of the community, contributing to their communities, unlike many other disabilities since that time when our concepts are different. And I believe that may be one of the most important contributions of the Sister Kenny technique was you will get back to doing normal, you will walk, you will be successful, you will be mainstreamed, and there was probably no other stream other than the mainstream at that time. You can take a look at this lady, Sister Kenny, and see that if she walked into the room, you did whatever she said you should do. And you know, everybody else there is afraid of her. I look at her and I'm afraid of her. The techniques were similar, but not quite as drastic, and this is Rush. Now, Dr. Rush on the left, and boy, there's a difference between Dr. Rush and Sister Kenny, and I'd like that warm, friendly greeting. But the Sister Kenny techniques worked, and it was really that process of you will succeed, you will overcome, this will not be something that leaves you in bed, this will not be something that we don't get you back, and I think that's still a wonderful technique. As you can see, there are more friendly ways to do it, and they may be equally successful, but rehab was an essential part of this, and the amount of one-on-one nursing and rehab care has really never been duplicated in the civilian world. In some of our military institutions at this time, in the acute care setting, we have this kind of one-on-one rehab. Once we get to the VA hospitals, it's not quite the same. This is a statement that, just again to think of the childhood, anything you had in this room gets burned. Not my bear, I cried. You can't burn my bear. I'm sorry, said the nurse as she dropped the bear into the bag. You wouldn't want someone to get polio just because you kept your teddy bear. And that was what was going on. This is a younger FDR, meaning when he was running for election on the second time with Eleanor next to him. And part of the concepts of his deception is that whenever he was standing, he was needed to use support. I'm using support standing, and I don't see that as a big deal. Just as often, he was in this kind of position with children. And he really was very sensitive to children, very good with them, and really communicated extremely well on this process. This is with him again, standing supported. That's his son, Elliot, who was frequently there to support him, and he's leaning back on a cane. This is his wheelchair. You can see this at Hyde Park if you go by there, and part of it. And he and Churchill really became extraordinarily close. Churchill, during much of the World War II years, lived in the White House and drank their scotch and smoked their cigars. It was something that he liked. His consumption of alcohol was somewhere around 20 ounces a day. He was able to tolerate that. His son died as an alcoholic, but he was able to do that. And I have the feeling he subscribed to the concept that two wrongs make a right, because along with the 20 drinks a day that he had, he smoked about 20 cigars a day. So the smoking and alcohol canceled each other out. They were very close, and Churchill was a frequent advisor to Roosevelt. It doesn't always mean they followed each other's advice, but they were very close. This is at a ball game with him throwing out, and again, just watching that, although he did this, and it was important for him to be seen, it was with the support of a friend. Churchill's cigar, you can just barely see there. Roosevelt looking healthy. We'll see over the years, towards the end of his last term, his face changes, his health seems to change. And it should be known that Roosevelt's family was really very, very much against him running for the last term. They were concerned for his health and didn't feel that he should do this. Even shortly before his death, which was in 1945, polio was close to his heart. Not until we've removed the shadow of the crippler from the future of every child can we furl the flags of battle and still the trumpets of attack. The fight against infantile paralysis is a fight to the finish, and the terms are unconditional surrender. Clearly this is in military terms. We see people use that for many things today. In light of that, this was World War II. During World War II, we can see why that language was utilized. This is about 1942 to 43. This is 1944, and if you look closely, you can see the haggard look on FDR's face at this time. So there are changes that are going on there, and certainly in this picture, there really is a droopy face. He has a cigarette in his hand. I don't know how his doctors let him do that. But clearly this is a less healthy individual than you saw in the before. And in 1945, during the second week of April, not far from the date that we're out, on April 12th, 1945, a little bit unexpectedly, but down at Warm Springs, he died. And the dimes we look at, the previous dime you saw was the Liberty dime, which had the picture of Liberty. But since 1946, we've had the Roosevelt dime, and that was in commemoration. And the fact is, the dime is the appropriate one. It was, again, part of his fight for polio. Shriners, still a hospital system that's intact, a charity hospital system that's intact, is the hospital where those iron lungs were visualized. They are still a powerful force in children's care, not just orthopedics, but all care. And the term crippled children was not a derogatory term, and the term cripple was not a derogatory term. It was a medical identifying terminology. In fact, the hospital that is now the Hospital for Special Surgery used to be the Hospital for the Ruptured and Crippled. Clearly, it wouldn't go today, but that was the name of it until they decided to go more politically correct. This is a note, only again, for your heart to go out to those children that were hospitalized. We want you to know that Thanksgiving Day, which is Thursday, November 25th, will be a visiting day from 2 p.m. to 4 p.m. I'd like to spend more time with my little child than that. Polio treatments, just hot pack support, respiration, whirlpool, exercise, stretching, bracing, surgery, and on the last column, seeing leg length discrepancies, and still something that's primarily corrected by external devices. Articles were present in all the news media all the time on polio and how to protect your child, and probably really discussing some of the things. Some of them were silly, but washing your hands was certainly part of it. Polio was part of our everyday life. That's howdy doody there. And the March of Dimes was a prominent process. The marketing was excellent, and I don't know whether others in that, but my mother made me wash with lava soap, just like this does. And others, and the fact was, it cleaned your hands. My hands would come in from playing outside and they'd be dirty. Lava soap had grit in it, and certainly it was really hand soap. I mean, you wouldn't rub almost any other part of your body with it, and the only time we did is when we thought we were in poison ivy, and then it was lava soap, and your skin was raw in doing it. So it was really hand soap. It wasn't face soap. It wasn't body soap, but it cleaned. And every time I came in from outside, probably all summer long, that lava soap was next to the ivory soap, and the ivory wasn't for me. The lava was. Living with braces was not unusual, and children functioned. And in most of my classes growing up, there was a child or more who had a brace on. At our orthopedic exhibit, this showed some of the leather braces. They're still some of my favorite braces. I think they were more comfortable than many of the braces we have today. Leather was living and breathing and took on your shape. Plastic, you have to take on its shape. So I understand the passing of custom-made, carefully molded, artistically sculpted leather braces are a thing of the past. We don't have those artisans left anymore. But they changed when you changed. They took on your shape. If they weren't perfect on day one, they got better. If your plastic brace isn't perfect on day one, it doesn't change. The children's braces were really much easier, and they didn't need to be as much. They didn't need to support the weight. They didn't need all of the extra stresses. And probably a brace like this in its day cost about $10. And it's why the March of Dimes was able to afford so much. You can say the same thing with the other equipment. They were made by numerous different sources, and all sorts of different shapes came on. Children with braces were encouraged to exercise, to play, and to, again, do all the things that we could do. I'll go through this quickly. Allow children to play with friends they've been playing with right along. I don't think that made any difference. Keep them away from new people. I don't know what that means, but it was part of the things but the next one which says, wash your hands carefully. And there's nothing more important than that in what we're doing. And telephone your local chapter of the National Foundation for Infantile Paralysis. No patient needed to go without care for lack of money. Your chapter will pay for what you cannot afford. And what a great statement and what a powerful message. 1945, when the war ends and people came back and there was disruption of living arrangements, more epidemics of polio. 1948, part of what the March of Dimes was able to do was also fund different research, and Salk's Labs was one of those that was funded. And we'll see if we have sound all the way through on this. This is again Basil O'Connor, who at this time decided to invest in polio research. And before this, he was really investing in polio treatment, but at this time he went forward and decided to invest in polio research. And it was just fortuitous that coming back from a trip in Europe, where Basil O'Connor was doing some work for the March of Dimes, he met Jonas Salk. He found in Jonas Salk someone who he felt matched his dedication, his energy, his commitment. And it was really Basil O'Connor's concept that he would make sure that Jonas Salk had what he needed. And he funded Jonas Salk remarkably. Jonas Salk was a researcher at the University of Pittsburgh at that time, and wound up having access to thousands of monkeys, personnel that he could not have otherwise dreamed of. And it was really the discussions between Basil O'Connor and the discussions between Jonas Salk that led to the investment, the funding, and the money, and the manpower that helped Salk to develop his first vaccines. Salk had large lab supplies. He was driven, and he drove his personnel. And that's what O'Connor felt was really important. There were people who felt that a live vaccine, not a killed vaccine, was the appropriate one. So in the healthcare community, not everybody supported this investment. In 1952, there were about 50,000 cases of polio in the United States, and this drove everybody involved in the March of Dimes to greater efforts. I was going to say drove them crazy, but actually drove them to an intense effort to do this. And O'Connor pushed on this, and when shortly after this, that Salk decided he wanted human trials, that Buzz O'Connor did everything that he could. And the first human trials were at a facility for retarded and handicapped children. And we were not as sensitive to that at that time. Frequently, prisoners, retarded children, similar facilities were used as a testing ground. We find that now almost hard to believe. It's not the way we do it. It certainly was nothing to do with informed consent, something we believe deeply in today. The early Salk vaccine at the Watson Home for crippled children, and then subsequently the post-school, it worked. And shortly after that, Salk went into more extensive trials. He not only injected more children, he injected his children, and he injected himself. He injected his co-laboratory workers, and they found no one got polio from this killed vaccine, and their titers against polio all rose. And so the joy on Salk's face here as he's looking at this was because there were early successes. There were advertisements. This is by Park Davis. What we do is, and I'll read, Park Davis produced the first trial vaccine in a pilot test. Since that time, Park Davis has become one of the largest producers of polio vaccine, Salk injecting one of his children. Polio is really part of orthopedics, and before the Salk and Sabin vaccines, it was almost all of orthopedics. There were no joint replacements. There was hardly anything that we would call sports medicine. There was trauma, and that was actually frequently handled by general surgeons. Much of what orthopedic surgery was tendon transfers, muscle transfers, realignment surgical procedures for polio. And the majority of polio, what surgeons were dealing with, were in children's orthopedics were in children's hospitals. There was a more extensive trial following this, and there was a trial of over 1 million children in the United States. A trial, again, something that I don't believe could ever be done again. But these were the early trials based on this, and once again was supported by the partnership between Basil O'Connor, working with the March of Dimes, and the early individuals. This was the first in McLean, Virginia. The early individuals were pioneers, they were called, or vaccination pioneers. Most of them do not really look like they're having fun, but they're going through it anyhow. And you, as parents, this was not that much fun, I can tell. I love that hairdo. And this was, I was saying, the polio pioneer was what they were considered at this point. The results of this trial of over 1 million children were not immediately publicized. And it was through a PR event. I don't know what we could even think, maybe like the lotto $300 million lottery win is a secret. This was a secret that they kept. They did not release the information, and it was brought about, and the news media were all there, and it was announced the vaccine works. And schools let out, children cried, parents cried. It was wonderful to see that we had an answer to prevent polio. And it wasn't long. And again, the thank you, Dr. Salk, was all over the country, and something that was very prominent. The newspapers, headline news, polio vaccine is safe, effective, and potent. And during this, Time magazine, killed virus vaccine was effective, and this cover, I believe, is 1954. And then the effort to vaccinate the country went fast, and there were efforts to get out the vaccination, but in real effort, there was very little resistance. We didn't have the concerns that we do today about autism and other vaccine bugaboos, and adults, children, families were excited about the opportunity to rid their community of this disease. This is again from the March of Dimes. Don't, remember me, that there's still a battle going on, and that was part of it. The news of the successful vaccine was 1955, 1957 mass immunization with this, and very quickly the number of cases dropped. This is what lines look like, but this was around the world, or at least the civilized world. These other pictures are in Europe and the United States, where these injections were held. It brings us to the next, because we subsequently went to the Sabin vaccine. Because of the success of the Salk vaccine in this country, Sabin had to trial his vaccine in the USSR. That was not trialed in the United States, and that annoyed him. And he and Salk never broke bread together. They really continued to have a friction through the end of Sabin's life and subsequently. We subsequently actually switched to the Sabin oral vaccine, not because it worked any better. It had some advantage in that. It was less expensive to produce and easier to administer. And so the live attenuated vaccine was an oral vaccine, and for many years became the primary process that's doing it. It replaced the Sabin oral vaccine, and the number of polio cases dramatically went down. The next headline for you is the first article of late progression of poliomyelitis. And this was out of Mayo Clinic. And once again, the Mayo was a very effective resource for a lot of information. 1979, the last wild polio. Since that time, we've had some vaccine-associated paralytic polio, and the number of cases has dramatically changed. Something close to my heart, the Roosevelt Memorial opening in 1997. There are a couple of images of Roosevelt for those of you who haven't visited there, and I'll show you this one a little bit better. This is my favorite one, and it seems very fatherly, very warm and touching. It's very different from the British one, which shows him standing with a cane, and this is the Britain's memorial for their appreciation to Franklin Roosevelt, raised by their own funds, but shows a very different Roosevelt that you and I image. This is when I visited there a couple of years ago in doing that, and it is a powerful exhibit in doing it. And if you look at the Roosevelt in this chair, it really looks a lot better than the Roosevelt in this chair. This is a little bit that tired Roosevelt we saw in the last picture before his death. And I think that most of his life, this is the Roosevelt that existed, and this was his last year. And yet, there was a lot of controversy over this. I know that we've had talks about FDR's splendid deception. I'm not sure I would call it deception. I think this was part of his way of overcoming a disability that he acquired late in life. And I don't think that anyone gave more, produced more, and could be receiving of our gratitude more than Roosevelt in ending polio. There are a few names, and we'll go through those, who really deserve credit for where we are today in this, and he's one of it. The next stage of this is really ending polio in the world. You know, we've ended it in the Western continent, South America, North America, Central America. There's no polio, and we've continued to battle in this. We have a few countries where we still have polio, and it's more political than anything else. China has essentially eliminated it. India has had a major effort, and it's just difficult to reach everyone on the same day so that they can get away with it. In Africa, we have areas that are a challenge because of the politics involved. This shows some global polio changes, that in 1988 there were 350,000 spread out around, and that has been reduced to much lower numbers, and those numbers can come down. I said that there were important names, and they include FDR, they include Basil O'Connor, they include Jonas Salk, they include Albert Sabin, they include Rotary International. And I commend our members of Rotary, but Rotary for the extraordinary charitable effort and healthcare effort that Rotary has made on a worldwide basis. And I think it has to be at least partnered with Bill Gates, who's pledged the funds that it needs to get better. He started with a smaller number, $250 million, went up to $1 billion, and my guess is he'll give what it takes because of his commitment to end polio. And I think that certainly preventing a disease is always better than treating it. Getting into our discussions on late effects polio, all of these terminology are the same, and some of them are preferred terminology. Late effects of polio, post-polio syndrome, progressive post-polio atrophy. It is the late effects of polio. It's not new polio, it's not a new infection, it's not contagious, nobody else gets it. It is post-polio syndrome, and those words mean the same. It is progressive. It increases over time. New fatigue, new weakness, new cold intolerance, sometimes breathing, swallowing, and speaking difficulty. Joint pain, the joints that have been subjected to no shock absorbers for a lifetime. It's not contagious. It is secondary to the disease, and these symptoms tend to increase over time. There is a decline in all of our mobility, strength, and function. I'm standing up there. There's a decline in my mobility, strength, and function. I didn't have polio. But it's magnified, it's intensified when those muscles are different. It is the result of a consequence of having had polio. And some of the other aspects of this are important. We'll go there. Probably somewhere between 10 and 1 million people had polio, to some degree, maybe more. There are people today who think polio doesn't exist anymore. We know that it does. Even if now there is polio in under-vaccinated areas, and for those of us who live in a country that's probably the most handicap-accessible country that there is, it still falls short. And it still excludes people with disabilities from full participation in life, and that's why the playgrounds was something that I was concerned with. In either case, polio still exists for you in this room. And there's easy answers. You should use all the aids that you need. You should listen to your body. Most of us ignore our body. You shouldn't. You should avoid activities that cause pain, fatigue, tiredness, and make choices in how you spend your time, your energy, and your dollars. Pace yourself in your daily life. You should rest frequently, and naps are not inappropriate. I've often been asked, what's new, what's exciting, what's in the research for polio? Not much. And I wish that weren't the answer. I don't think enough money is spent on it, and I don't think it will be. I think your treatment plan, and those of you who have been in my office have heard pretty much the same things, consists of what's here on this page. And I wouldn't wait for some new exciting miracle to come down the line. I think that's not, in my mind, very likely. Medications do play a role, but not particularly extraordinary ones. Aspirin, Tylenol, Advil, and occasionally some of the steroids or non-steroids. Exercise is key, and you can't start early enough. For most people, it should start yesterday. And every healthy muscle should be maintained appropriately. As with all of these things that I'm going to go on, there can be too little and too much, and you need to know your sweet spot. And exercise with neuromuscularly compromised patients needs to be what we call submaximal. In high school and college, we learn, you push till your limits. That's not what you should be doing. If you push to your limits, you do harm. And if your therapist tells you that, you need a therapist that's more knowledgeable in patients with neuromuscular disorders, and that's getting harder and harder to find today. You need to use the various assistive devices that make life easy for you. And those are very personal, but whatever it is that makes you more efficient, more independent, and less demanding on your body. I know we had a talk, save our shoulders. I think that's important in doing it. Precautions. Don't do things that can get you in trouble. You're not going to heal as quickly, you're not going to get better as quickly, and you don't have as much reserve capacity to do things. Surgery is rare. I'm a surgeon. I do surgery every week, and I've done surgery on people in this room. I try hard to avoid surgery in patients who have had polio. They don't heal as quickly, they don't heal as well, it's more complicated, the rehabilitation is more difficult, and as you know, the anesthesia is more dangerous. An orthopedic surgeon friend of mine who had polio and has been a surgeon all his life underwent surgery last week. And he and I were talking before he went in. His anesthesiologist didn't have a clue. And he's a university professor at a university facility. His anesthesiologist didn't even know who to refer him to for the assessments. And finally, after talking, we got him a pulmonary assessment. We got him an anesthesiologist to communicate with his anesthesiologist. And so any surgery should be, if somebody thinks it's not a big deal, he doesn't understand. You need to not hurt yourself. Every additional injury will lose function for you. If you break anything, you're going to lose function. You're going to be incapacitated. And I think it means injury prevention, whatever that is, should be at the top of your list. Maybe coincident with the top of your list is family support. And I don't think there's any substitute for that. The people who really do best with this are part of a team effort. And having family support is what makes the difference. If you have it, you know what I'm talking about. And if you don't have it, I don't think that there's a good substitute for it. Your home environment should be conducive to you and may need some changes. There are very few homes that are totally built with your needs in mind. The bottom one I think is important and probably getting hard to do. Forge a doctor-patient partnership. You and your doctor need to work together. And the kind of doctors that I think that you need are not always orthopedic surgeons and probably not frequently orthopedic surgeons. I think you need a rehab or physiatrist type physician who knows your limits and your needs. And I think the next most important doctor, and I know I've seen a lot of neurologists on the March of Dimes board, I think more important is a pulmonologist. I think breathing difficulties have more solutions. I think the neurologic solutions are not solutions. We don't have many medications or treatments for neurologic deficits. We do have treatments for the pulmonary deficits, and I know that's important. I am extremely proud of this title that many of you have come into my office with. Are you Joyce's doctor? This is a picture probably about 20 years ago when Joyce and I were at a TV program with a similar discussion. And I have been extremely proud to be Leonard's doctor and Joyce's doctor, and I think that's as high an accolade as there is. Joyce was an extraordinary individual, as many others are. She had a real commitment to this group. Her commitment was communication and education. What better areas to be communicated, and she wanted to make a difference, and she did. And I applaud her efforts, and she's really the reason we're sitting in this room. Some of the things Joyce and I once talked about, and this I had developed with her, smile first thing in the morning. Get it over with. It really isn't easy, but it's important. In a communications course that I was participating in, somebody I knew for about 10 or 15 years, and we had this comment, and he came up to me and extended his hand and had a smile on my face, on his face, and said, "You should smile when you greet your patient." And I said to him, and I said it to him, I said, "John, I've known you for 15 years. I never saw you smile." And I really hadn't. And I think that smile is powerful. So smile first thing in the morning. I could be unstoppable if I ever got started. And I think this in me, you really need to. If you need to take charge, ownership of your getting better, you need to know the things that are important for you, and you need to do them. And you need to know the things that are bad for you, and you need to stop doing them. There are no substitutes for those kind of things. You are unique, and the fact is, I don't know any other group that's more unique than those patients I treat with late effects polio. I don't think any two of you in this room have exactly the same combination of effect from this condition, but you're also pretty much the same, and that's why we can be up here talking about things. I'm proud to have family members in here because I think you're very, very, very important. I think that you make the patient's job easier and you make my job easier. Many times I give patients a list of instructions that alone they really can't follow. With your help, they can. I thank you for this opportunity. It's really a privilege to be here. I think that this group is remarkable. I've watched you grow from a small room that we used to meet in the Bridgewater Library, this is an important process. You in this room taught most of your physicians what they know about polio. I know Joyce and I learned together. I have a folder that we acquired together, and we would provide each other. Every time Joyce would find an article anywhere, she'd give it to me. Every time I found an article, I gave it to her. And it was part of the learning that both of us were looking forward to doing. It is a privilege to be here. I thank you for inviting me. And I do have questions. Is that what you'd like me to go to, Lee? Or?
Yeah. Hello? Hello? Can you turn up the volume a little bit? What we have to is two runners, and they're going to run the microphones to people. So if anyone has a question, don't actually ask the question until you have the microphone in front of you so everyone can hear. Although this is pretty low. All right, here. You take one.
Lee, do you want me to start with the ones you've sent me?
Sure.
Okay. These are questions that you in the room have sent to me. I promise I didn't make any of these up. Is the medical community teaching doctors about post-polio syndrome, and where can we find them? No. Simple answer. When I speak to young orthopedic surgeons and physical therapists and physiatry, it's not on their radar screen.
There aren't enough of you. There are other priorities, and they prioritize. So the answer is really no. I think you may need to teach your doctor, and that may be possible. There are probably a couple of us that are still educable, but it really, and it's going to be harder and harder. There may be people who have some experience who have trained in other parts of the world, but in this country, we haven't had polio in a long time, and our schools do not have this. Some of the Shriners Institutes still have a little bit of an educational program. The last lecture at a major meeting that I had that related to it was an extraordinary lecture on it from again, somebody from Shriners, and he gave it, and that was about 15 years ago. About 5 years ago, my torn rotator cuffs, both shoulder, were diagnosed as beyond repair. Have there been any technology that would allow them to be repaired? Most of you that have walked with your hands have rotator cuff tears. And the answer is yes and no. Most patients, and there are exceptions, whose MRI shows an atrophied muscle, not just a tear, but muscle atrophy, and that's the majority of chronic tears. An acute tear is a fall, or you throw a baseball or something like that. If I'm a 27-year-old baseball pitcher in the major leagues who tears my rotator cuff, that can be repaired in doing that. If this has been a chronic tear with a muscle atrophy, I don't have anything to sew back together. And so the majority of times the answer is no. The rehab is challenging. It means you've lost an arm. We need to protect that repair for a number of weeks. And so for those who have usually worn out their arms because they needed to transfer for self-care, for hygiene, and so you've lost one of those arms. And so it's not. There are some things that we're working on. They're not effective, and there may be in this area, I didn't promise a lot of other things, but there may be in this area some promise of better patches in the future. Can polio survivors safely have cosmetic surgery such as facelift, eye lift, breast lift, Botox, filler injections? And you know, and maybe I'm what we look like is important. I had my wife help me pick out my tie, we care about what we look like in doing that, and we should. And I think that's when I have a patient in the hospital who's been there in a few days, and I see that this for the first morning, they're washed, they're clean, they're shaved, they're brushed, and I know they're getting better. So caring about your looks is important. I think that certain things under local anesthesia probably will have no more consequences for you than anybody else. I've never been enthusiastic about cosmetic surgery. Personally, I think the most beautiful thing about almost anybody is a smile, and that doesn't take any Botox. I think, get again, that smile in the morning, a little brightness in your eyes, and attitude probably are better than the other things that were mentioned there. But everybody has their own thing. I think it has dangers. We read about in many of these facilities, they're usually not in a hospital. They're usually in without really anesthesia on purpose. And I would be frightened to have you there. Which cholesterol medications are recommended for post-polio patients? I'm going to come up with my answer: garlic. You know, there are a lot of statins which seem to have some difficulty with many patients, and I think the less drugs that you take, the better. But you know, most of our cholesterol that's elevated is ours. We make it. But if you have anything in your diet that is not low cholesterol, get it out. Even if you like it, there are substitutes today for everything. The true Mediterranean diet, which is a I'm going to say the true Mediterranean. I was going to say a glass of red wine. If you've been in Italy, it's a bottle of red wine. But it's a certain amount of wine, small fish, sardines and little bait fish, not a slice of tuna and so on, but the small little oily fish that have the good oils and olive oil is probably also a positive effort on it. Red yeast rice and so on. I think that all of these need to be individualized and may be effective for you, and I think there's nothing wrong with trying the food supplements in this area. Medicare programs for disabled individuals, there are some, and I think that these are available. You can go and yet they fall short. They won't meet all of your needs. that they will cover, as you know, wheelchair, scooters, lifts, chair lifts, physical therapy to a certain amount, part of your doctor visits, so all of those are part of it. Long-term opinion on late effects polio, I think I've given that and I've covered that, so it's a progressive disorder. It will increase over time. You should plan for your future to be less functional 5 years from today than you are today in doing that, and make accommodations for that, and you should look to counter that. Your exercise program is part of it. Your learning to do things with less effort and work in doing it. How can I make my family understand that I have new physical problems? They can't seem to realize that I cannot do any more than I used to do. I cannot do any more what I used to do. Help. I'm not a counselor, and I'll say on that. And I believe meetings like this, if your family's here, they probably do understand. If your family's not here, probably anything you say won't help them understand. In doing that, I think you need to know your limits. I think you need to commit to what your limits are. And I think you need to not let someone else determine what you do and what you don't do, but rather your own understanding of your capacity. I get this question not just in disorders such as late effects polio, but in almost anything that I'm seeing a patient with. And, you know, women are from Venus, men are from Mars. We've got different chromosomes. Men don't see dirt in the corner. We don't know how to wipe a counter. We can't fold a shirt decently. And we need help picking out a tie. So there are a lot of things that are different in men and women. We don't communicate well on any other issue. I don't see why we should in this. But I believe the best situations are where there's an open line of communication and where there's a good supportive relationship. And I think it's so valuable that you have to keep trying and understand that there's a barrier to us really communicating well. We're not really a sympathetic culture here in New Jersey. You know, Christie's our governor. Have you seen one little bit of sympathy? It's in your face. But so is a lot of other New Jersey. It's that. Sleep patterns. I think those people of you that are having swallowing problems, talking problems, sleep patterns, probably have some bulbar involvement, and I would suggest a pulmonary assessment. Should I get sleeping pills? I don't like them. I think they create an abnormal sleep. It's not a restful sleep, and I wouldn't recommend it. Falling is a big problem. What are your recommendations for preventing falling? Whatever it takes. And I know I've talked. If a cane isn't good enough, you should use a crutch. If one crutch isn't good enough, you should use 2 crutches. If that's not good enough, you should use a scooter, and so on. You need to do whatever it takes. Do things slowly, efficiently, cautiously, and the things you can do safely. If you're doing other things, you're going to get in trouble. Prevention of kidney stones in sedentary people, high fluid intake, and sometimes some of the urinary acidifiers. And there are people who are stone formers, and people who are less active are stone formers. I think that's my list, Lee.
Any questions?
Thank you. My name is Susan Gordon-Ryan, and I traveled from New York with my family. And it seems like New Jersey has got such a strong network for post-polio, and I was wondering if you have any recommendations in terms of maybe educating doctors in the New York area, or any networks that people may have to kind of get the information out. Again, I come to New Jersey for information, and I'm on the list for the post-polio network here, but New York just doesn't seem to have any resources for people.
I think you need to find someone to wave your flag, and I'm sorry if you're having trouble. I think it's not what we're training physicians for today. I think, you know, again, I've been part of a lot of mentoring programs. I know a lot of bright, dedicated, energetic young physicians. I can talk to them about ACLs, shoulder repairs, fracture care. If I talk to them about polio, it's another wavelength. So I think you need to find somebody who's tickled by that opportunity, who's challenged by the gap that's there, and it's not easy. Probably in going through this community here has had a lot of different physicians, and have probably come up with a small handful that they feel truly understands them and can direct their care knowledgeably and sensitively. And once again, I think that number is getting smaller. And we may wind up having to regionalize something like that. There is, and I haven't looked at it lately, there is published a list of those physicians and healthcare professionals that self-anoint themselves as being familiar with polio. And I haven't looked at it lately. Lee, is it still available? Okay, and you may look, I think you need to search, and the search is worthwhile because without it, it's really hard. You may find somebody who can tell you somebody else. Rehab may be your first step, not orthopedics. Pulmonary may be a first step, not orthopedics.
And I had that, you know, I learned the hard way with the, I had a colonoscopy years ago, and I wound up in intensive care because of being over-medicated. So that is key. With the anesthesia was just too much.
And if your anesthesiologist poo-poos, you need a different anesthesiologist.
Yeah, we got very aggressive.
If he really says, no big deal, I don't need to worry about this, because what he's done is
very serious.
Discount what you've just now told him. At your peril, he's done that.
Yeah. Thank you, Doctor.
Yes. Maybe stand up so everybody can hear you. I can hear, but if you...
There are several things like orthopedic and podiatric that diabetic. Lots of things are covered, but post-polio is like not important.
Diabetes, we have millions of people. It's a growing disease. It's probably the worst disease in our country today. More people go blind, go on dialysis, lose limbs from diabetes. So we have lots of diabetic doctors.
I know. But what can we do to make our voices heard? You know, to have similar types of help.
You know, I think Lee and Joyce and Arthur and Leonard have made your voices heard. Someone has to be listening at the other end, and maybe that goes to the communications effort needs to be ongoing. When we first talked about late effects polio, post-polio syndrome, there were articles in the newspaper all the time. I would get them from around, Joyce and I would get them from around the country, and it was this, everybody discovered post-polio syndrome. It was really the writer that discovered it, and these trickled out over the years. You're not going to get many of those anymore.
I just wrote a letter to Medicare, and I told them that I'm not going to stop fighting until they cover the cost of a rolling walker that I need in the morning. I'll just keep fighting for it.
And I don't disagree with you, and yet they have their lists of what they cover, and
well, that list has to be adjusted.
And currently, among the biggest budget cuts, both sides. I'm not going to give any favorites on this, but the Affordable and Available Health Care Act cut $100 billion from Medicare over the course of the next decade. Where do you think that's coming from? And where that $100 billion was supposed to go is to fund other people, but they cut $100 billion. Now, I don't know what's going to actually wind up happening, but if they're going to cut the budget, and both sides are cutting budgets, just which way and why,
I realize that.
and both sides are cutting Medicare.
Right.
So expanding Medicare, and I'll say for physicians, I think when I go to something and physicians say, we want to fight for higher fees, I think you're kidding. And I think the likelihood of anything coming out of Washington in Medicare or anything else that's going to give doctors higher fees or patients more coverage.
Right.
I think we're all headed for higher copays, more personal ownership of what we're doing. And I'm going to say if you need a rolling walker and it's under $100, you ought to make that money. And I'm not saying that's bad. I'm saying, should they cover it? Yes. Reality is pick your battles and those that you think you can win. I hope you do. But in the meantime, if you need something, access it. It's too important to do without.
Right, right. All right, thank you.
In the back, yes.
Good afternoon, Doctor. My name is Daniel Currier. In 1956, I came down with this lovely thing called polio, and raised in Kearney in a tough old Irish Catholic family, and learned that we're going to beat this. Looking around the room, a lot of yous that are coming before me are showing me the path to walk, or use a better device to walk with. Right now, the question on my mind is because of what I'm going through. Back in the 70s, some of the North Jersey gang, I hope somebody in the room remembers the name of Dr. Wilner. He was an ortho guy from...
he was at Orange Hospital, I believe.
Yeah,
Yes.
and he had his own practice in North Arlington. And when I got out of the Navy in 1974, I was 21 years old. And for some reason, that doctor, he kind of embedded something in me. He said, for some reason, Dan, don't ever let anybody put cortisone in you. Now, I don't know if that meant because of, you know, growing up with polio or whatever. And about 3 years ago, I, with some of the other symptoms that I'm having because of beating my body up for all the years, and you can beat it, and you can do this, and you can do that, well, learning that, well, maybe I should have listened, and we're having the difficulties. Doc, your opinion of cortisone in post-polio patients?
And on that, I'm going to say that steroids are a wonderful medicine and they're a terrible medicine. They have good things and bad things about them. And I think somebody saying don't ever is sometimes giving you too strong a direction, because there may be circumstances. There are patients with respiratory difficulty that nothing else works as well as steroids. And steroids have been around for 70 years, and we haven't replaced them yet. They should be used carefully, wisely, selectively, the lowest amount of dosage for the shortest period of time. They help, and they produce some negatives. Long-term steroids make your muscles weaker, your bones weaker, and change some of the look that you have. That may be less important than the first two. On the other hand, if that helps you breathe, boy, that's important. If it gets rid of enough of your inflammation in your joint that maybe 6 months, you get 6 months of better walking, I think that's important also. So I think it needs to be a decision that's made carefully. I like decisions that I share with my patients, and what I'll try and do is say, here's the pluses, here's the minuses. Where does that fit in your choice? Where possible in doing that. Thank you. Lee, anything? I really appreciate the opportunity to be here. Go ahead, last one.
Right. My name is Ted Pachalski. I had polio and contacted polio in 1957. In the last 10 years, if I take any medication, aspirin, I blister. A few months ago, I was tested, and I'm not allergic to any aspirin or anything of medication. Is this associated with the polio?
I don't believe so. In fact, I'm going to say I don't know anybody else that's really told me that. Certainly there are things about late effects polio that we're still learning, but I don't believe I've seen that as a regular entity. And I would try and find those groups that you don't react to. You might, you know, if you've been allergy tested and they can't find anything, there's got to be some other factor. Polio is not an autoimmune disorder, which we see those reactions to, and so it would be an atypical response. Thank you.
Okay, thank you.
Thank you, Dr. Hirsch. Thank you very much. Yeah. Sorry that you can't stay for lunch. I know that you have another engagement to go to, and you know, we're sorry that you couldn't stay for lunch. But
again, I'm sorry to cut it short. I would really love to stay. It is my uncle's 100th birthday, and he's a dear uncle, and he's 75 miles away, and I'm supposed to be there in 15 minutes.